Welcome. This is Dr. Santhosh Kumar, Assistant Professor, Department of Prosthodontics and Crown and Bridge, Vinayaka Missions, Sankaracharya Dental College and Hospital. The topic for today's lecture is on post-insertion problems and its correction in complete denture. Most often, we rehabilitate completely edentulous patient and they return back to us with a certain set of problems which the dentist should know, and the knowledge about this is very, very essential. So let us look into the different types of problems a patient turns into your OPD after insertion of a complete denture. So the first problem he will turn out is with pain. Second is the patient is not happy with the denture or the aesthetics which you have provided in the denture. The masticatory efficiency, the patient is not happy with the masticatory efficiency or he is not able to chew food properly. The denture is very loose. The patient is not able to, patient is not able to put the denture in the oral cavity and having a stable retention. Altered speech, when the patient is conversing to his fellow friends or colleagues, he is not able to convey the message properly to the other relative, or there is a loss of taste sensation, which we call it as paresthesia. So the main causes why the patient comes to the dental clinic because of pain is either the first thing is there is overextension of the periphery. So how can we correct this? So this can be corrected during your border molding stage. So immediately you have to understand that during border molding, you have overextended your borders, which is impinging on the soft and hard tissues. And because of that, the patient is got pain. Second, the poor fit of the denture. Poor fit of the denture can be either due to a very bad primary impression, or there are some other cases like xerostomia where there is no interfacial surface tension for the patient and there is no suction which is there, so that which keeps the denture in place. Insufficient relief of your frenums, your labial or your lingual frenum, because these are soft tissue musculatures which has to be relieved for ease of the patient and for the comfort of the patient. Incorrect occlusion and cuspal interference. So you've done something wrong in the teeth setting procedure where you have not followed your glass plate relationship, or there is no articulation, or you might have gone wrong in any of the flasking, packing, flasking and dewaxing procedures where there is a slight change in your packing, and that is resulted in an improper denture fit. Teeth is off the ridge. You've not placed it properly. Sometimes the lower mandibular denture, there is too much, there is a cramped surface so that there is no space for your tongue, and the tongue actively hits against your lower denture, and this causes the tongue to displace your lower denture. Retained roots, unerupted teeth, or sharp bony spicules. Quite often this thing happens when the patient comes to us. We do not recognize or we do not go into for a radiological examination. We don't go in for an OPG, orthopantomogram, so that we can visualize the presence of any bony spicules, or is there any retained deciduous tooth, or there are any retained tooth which is there, or there are any retained roots during extraction. So all this we have to understand, and for this to understand, it is very necessary for us to go ahead and take an OPG. Irregular knife edge or V-shaped ridges, which has already got a very sharp topography. So you will have to do something called as an alveoloplasty to reduce and retain that particular surface. Pressure of the mental foramen, because when you don't give a double spacer in your incisive papilla or your mental foramen, there is going to be paresthesia, which is also called as an altered taste sensation, and along with it, there is going to be pain. Allergy, if the patient is suffering from any denture allergies like your methyl methacrylate, you have to do a patch test before going in with respect to fabrication of the denture. Then infections with any fungal infections like candida, difficulty in swallowing and sore throat, and if you are impinging on the severe undercuts. So all these factors put in together primarily causes pain, which allows, gives which so that it gives so much of pain that the patient is not able to wear this particular denture. All right. So where does this pain actually originate from? It originates from three different regions of your complete denture. It either originates from the borders, it originates from the basal seat, or it originates during mastication. So let us look into it. So if the pain is originating from the border, okay, I just told you that how do you correct it? If the pain is originating from the border, you should understand that you have overextended the border or underextended the border. Now, how come both overextension and underextension causes pain? Overextension readily impinges on the soft and hard tissue, so it gives rise to pain. But whereas the underextension, there is a space between your sulcus and the denture borders, and on mastication, the food bolus enters this particular area, and over a period of time, if the denture is not cleaned properly, then you will have slight amount of inflammation there, which leads to pain. So please understand both over and under extension. If there is an under extension, you have to go in for a bottom molding again, and then you have to refabricate the denture. If it is an overextension, you can actually decrease the overextension by a trimming of the excess areas. Now, the pain in the basal seat. Pain in the basal seat will either arise either from the denture or from the ridge itself. If it's the ridge, then you have to understand that you have to know whether there is any remaining undercut, remaining root which is present, which you missed it in your OPG, or you extended to the full depth of your undercut, and then it's causing pain. But if it is because of the denture, it's because either the denture is rough, or there is poor fit, or if it is impinging the mental foramen causing paresthesia, allergy to a denture-based resin, which you have to do via patch test, or pressure area where you have a improper impression or an improper cast or warpage of the denture base. Okay, so if you that's the basal seat. Now coming to the occlusion, this plays a very, very major role. You have to understand that during occlusion, when you're fabricating a complete denture with occlusion in mind, your centric relation, centric occlusion, and your maximum intercuspation should all coincide with each other. So centric relation is a bone-to-bone relation which cannot be changed, and this centric relation should be equal to your centric occlusion, which in turn will be equal to your maximum intercuspation. Okay, so when all these three things coincide, that means you will have no pain. If it doesn't coincide, then there will be pain. So the first thing, if the patient says he's got some pain during occlusion, then the first thing you have to understand is you've gone wrong during a jaw relation, and then this has to be repeated. Okay, and so sometimes during occlusion, you might have done everything properly. Your centric occlusion relation is coinciding with the occlusion and with the MIP, but after articulation, the teeth setting principles are, if it's not properly followed, even then it can raise to pain. Okay, like your cuspal interference, and sometimes you place the teeth which is off the ridge. All these things lead to pain. So I told you overextension or the underextension. Okay, overextension interferes with the muscle movement. Underextension, it breaks the seal. So there is no seal which is created, and the food particles go inside this particular area, and over a period of time, it causes pain. And improper trimming, whether the thick or thin borders. We have to understand in the border area, both the length and the width of the borders is very essential to obtain a border seal. We mostly concentrate only on the length, but the most important thing is we have to concentrate both on the length and the width. I would go to another extent and say the width of the denture base is even more important than the length of the denture base. The denture border. Sometimes pain due to the occlusion, this I explained to you very clearly. Vertical dimension, centric occlusion, centric relation. Okay, all these should coincide. And if you have increased amount of vertical dimension, then you will have angular cheilitis, which is at the corner of the mouth. If you have decreased amount of vertical dimension, then you will not be able to properly masticate, and it will cause neurological pain. Teeth of the ridge, most commonly we face it in the upper buccal, sulcus on the working side, and tuberosity of the opposite side. Okay, Now you find that there are certain interferences in when the patient is actually masticating. But how do you rectify these particular problem? Please do not adjust your occlusion intraorally. There is a particular method called there is something called remounting. You have to remount this particular maxillary and the mandibular dentures with the existing master cast. You'll have to remount it again. Okay. So when you cannot see the problem, you cannot eliminate the problem. Okay. So the contact on the inclines can cause the denture movement. It may cause pain or reflex avoidance. It may make interference, which is difficult. So when you do a clinical remounting procedure, when you keep it in the intercuscuation and you take a bite and do a remounting procedure. How do you do it? You place a thin sheet of wax or a bite registration wax between the maxilla and the mandible, ask the patient to bite and take this particular relation which you've got and then transfer it to the articulator. And then you do something called as a selective grinding. Okay, you do selective grinding by using the Bull's law, upper buccal and lower lingual. So these are the non-functional cusps. You reduce these particular areas and then do it. If you do it intraorally, you will not be able to see all these particular small interferences, and you will trim it so much that you will cause a loss of occlusion. The second most important point why the patient returns after a complete denture is that the patient is not happy with the aesthetics which we have provided. So what is the major reason why the patient is not happy with the aesthetics? Because your vertical dimension is too small. The vermilion border appears thin and the wrinkles occur around the lips and the chin. Apparently, it gives you a class 3 sort of a relationship. So when this happens, you have to understand that you've not done a proper jaw relation. You have to go back to a proper jaw relation and repeat the procedure. Okay. Another important thing during jaw relation, we have to see the amount of proclination which you're giving for the maxillary denture, which in turn will support the lip and will give support to the cheeks also. So you have to make sure that you have some amount of proclination in the maxillary arch so that it supports your cheek and your lips. So these gives you an aesthetic appearance. But if you fail to do so, then you have to build up the upper denture. Yes. So how do you know that what is the sort of, some patient will come to you by saying that, doctor, I'm not happy with the teeth which you have given to me. I'm not happy with the amount of visibility which is there for this particular patient. I'm not happy with the amount of show I'm giving to you. So what you have to consider? You have to consider the Dentogenic Concept given by Flush and Fisher in the year 1950, SPA, sex, personality, and the age. So you have to have a thorough history of the particular patient, both medical and dental, and you have to come to certain, conclusions. Sex, personality, and age. Sex, you have to first find out whether it is a male or a female patient. Is the male during his young ages, is he in his adulthood ages, or is he a pediatric patient? First one, if he is a young male patient, you have to give a long and a sharp incisal edge kind of a teeth, okay? And if it is a very old patient, you have to give a slightly yellowish sort of a tooth and which some amount of attrition present. Okay, then the personality, you have to understand whether the personality of that particular patient is aggressive sort of a personality or a calming sort of a personality, and treat accordingly. And the age, like I told you, if it is a younger patient, you will have to go with a more milky white sort of a tooth. And if it's an older patient, you have to mimic the bruxism and bruxism and give it to the patient. So this customization will help the patient not coming back to you with problems like I'm not happy with the teeth. Another concept is the concept of the face itself. You have to first understand what type of face is the patient got. Has he got a square arch, square face? Has he got a tapering face? Has he got an ovoid face or a square tapering face? So once you come to an understanding that this is that particular type of the face the patient has got, you have to choose that particular type of teeth set. For example, a male patient will have a very long and also sharp incisal edges, but a female will have a short or a wide, okay, teeth, and the incisal edges are very rounded off. So it doesn't give you that aggressive feeling. Male prefer to go with the slightly yellowish tinge of the tooth, and female, since they want a milkier white sort of a tooth. The females understand that they're aesthetically very much oriented, so you have to give them more amount of show. That is why when you do your jaw relation, you have to give minimum 2 to 3 millimeters of incisal visibility for a female patient and 0.5 to 1 millimeter for um, the male patient. If you keep all these concepts in your mind during your jaw relation or during your trying phase, you can avoid the patient coming back to you with poor aesthetics. See this one, a classic example where the vertical dimension of occlusion is less. Okay, the patient has come back to you, and you see there is angular cheilitis. So this can be improved by increasing the vertical dimension of that particular denture. Now, the third and the most important thing why a patient comes to you is because of masticatory efficiency. Masticatory efficiency, the patient is not able to bite. The entire thing why the patient has come to you is for function and aesthetics. Even if he's happy with the aesthetics, he or she is not happy with the the function. The patient is not able to bite, and the patient is not able to savor and bite the bolus and extract nutrition from it. So what are the different things? It may be because of a cuspal interference, unbalanced articulation, or if you've given a flat teeth. Dislodgement during eating, the borders, there is overextension, I already talked to you about that, and improper tongue space. A very important thing is you have to understand the tongue is a very important musculature in your oral cavity. If you do not provide adequate space for the tongue will guarantee, will surely displace your lower denture out. Okay, so it is very essential for you to contour how you are going to place your dentures, and equally you are going to make sure that you are in comfort with the teeth and with the tongue. So it should never happen that your lower denture should encroach your tongue. Okay, so if it encroaches your tongue, it is just going to push your lower denture outside, and the patient is going to come back to you stating that I'm not able to eat properly, and the lower denture keeps displacing. So inefficient eating, again I told you, because it is because of occlusion. When you don't give a proper vertical dimension, if the proper vertical dimension at occlusion is less, the patient cannot give the required amount of masticatory force to actually chew the bolus. So if the vertical dimension of the patient has to do more amount of muscle chewing, and then after some point in time you will have tenderness on all the masticatory muscles. So it is very, very, very essential that you give a proper vertical dimension at occlusion to give the maximum biting force so that the patient can chew on the bolus. So then if you give a blunt articulation in patients, sometimes you go for a monoplane occlusion where the patient is suffering from bruxism. In those particular cases, you might not expect a good masticatory efficiency. Then, the fourth important point why the patient comes to you is because of the patient is not happy with the fitting of the denture. The patient is not happy either. This can be either of two reasons. Either there is a reduced retentive force, or there is an increased displacing force from the structures, from the oral structures. Okay, so what are the reduced retentive forces? First is the lack of the posterior palatal seal. When we do not establish the posterior limit of the border, this is a very common occurrence. So by that I mean is, if you do not record your posterior palatal seal area by defining your posterior vibrating line, okay, and your anterior vibrating line, if there is overextension or underextension, if there is overextension, definitely there is going to be an increased displacing force from the soft tissue and a gagging reflex is going to happen. If there is an underextension, then there is no posterior palatal seal. So when there is no posterior palatal seal, the denture is just going to fall down. So it's very imperative for you to locate the pterygoid hamulus, draw a straight line across the either side of the pterygoid hamulus, and then draw the anterior vibrating line, which is Cupid's bow in shape. Do it in an indelible pencil, mark it with a spirit, and then transfer this in your maxillary denture to locate the borders, to know whether it is underextended or overextended. If it is overextended, you can always trim. If it is underextended, you have to again go in for a posterior palatal seal. Okay, underextension of the borders. Okay, proper impression pressure if you've not given, or the material is set too early when you're taking a secondary impression, causing an underextension. These things will happen. Then xerostomia, when the patient doesn't have saliva, there is xerostomia. So basically, the denture is stuck to your maxilla, or the mandible is stuck to your tissues because of the interfacial surface tension, and when there is no saliva, there is no interfacial surface tension. In these particular patients, you can give salivary substitutes, artificial salivary substitutes, and whenever you give an excess relief, for example, you've given a big relief for the incisive, papilla, you've given incisive frenum, buccal frenum, if you've given a big relief, then it is not going to stand. So these are certain forces, certain things where you find a reduced retentive force, and increased displacing forces when there is overextension. I told you, when you press against the musculature, it is going to displace. When there is a flabby tissue or occlusal errors, flabby tissue, you have to correct it by alveoloplasty, remove out the flabby tissues, or when you do not have enough extent of the ridge, then you will have to do an alveoloplasty and then a vestibuloplasty, and then you have to increase the length and the depth of the sulcus. Occlusal errors, that means you have done something during the tooth placement or teeth setting, you've not followed your teeth setting principles. Sorry, teeth setting principles, so then there is an occlusal error. So the denture is dislodged by eating, common complaint. So what is your inference? Your inference should be the patient either during cuspal interference, unbalanced articulation, teeth outside the ridge, cramped tongue, overextended flange, or an unstable denture. Now, I told you the poor denture fit can be either due to a decreased retentive forces or an increased displacing forces or an inadequate supporting structures which you have to negotiate. Especially in cases of flat ridge, okay, you will have to, which is Atwood's type 5 and type 6, you will have to think of certain surgical pre-prosthetic procedures such as vestibuloplasty and alveoloplasty. Vestibuloplasty, if you do not have enough amount of sulcus, alveoloplasty, if you have any extraction sortant which is remaining. All these fibrous tissues should be removed, and it should be made firm and resilient, and non-resilient soft tissues, okay? Yeah. Altered speech or phonetics. Another major complaint why the patient comes to you is that, doctor, I'm not able to converse properly, or when I'm conversing, I'm not able to put across this particular message to my friend or relative or somebody else. So I am not able to, pronounce certain words, certain letters properly. So when you are actually delivering this particular denture to the patient, it is imperative for you to check these three different sounds. Your sibilants, your bilabial sounds, and your labiodental sounds. Your sibilants is S, okay? Your bilabial sound is P and B, and your labiodental sounds is F and B. So if the patient is not able to produce S properly, that means the inference there should be, okay? You can do this during your wax trial, okay? The inference when the patient is not able to say yes properly is that the overbite is more. So that means your vertical dimension at occlusion is more, and then you need a bit of freeway space. There is no freeway space in between. So slightly open up or increase your vertical dimension. If you do this, you will have a proper S sounding. Then P and B, which is a bilabial saw, incorrect incisor position. That means you've not positioned your anteriors properly. Okay. F and B, upper anteriors are placed too labially. So F and B, if it's not produced properly, that means you placed your anteriors proclined or labially. So this table I have taken from Shari. You can refer to the third edition of Shari. Very clearly given, when there is a whistling on whenever the patient is producing an S sound, that means the too large airspace on the anterior part of the palate, and you have to reshape the anterior part of the palate by thickening the denture base. That means you have to add some amount of material there. When you have a lisping and when the patient is saying yes, that means that there is a smaller anterior airspace. So which is we have to thin the palatolingual area. So when you thin the palatolingual area, adequate amount of space is what. Indistinct T, H and H sounds, that means inadequate interocclusal space or your freeway space. You have to reduce the thickness of palatally maxillary denture and lingually mandibular denture base and reduce the vertical dimension. Okay, so that means basically the inference is that if you give a proper freeway space of 2 to 4 millimeters, you will not have this problem. T sounds like TH, that means the upper anterior is placed too lingually and you have to place it slightly buccally. F and V sounds are indistinct. Improper position of the upper anterior teeth either vertically or horizontally. You have to reset either vertically or horizontally so that they contact the lower lip at its highest point during these sounds. Another important thing is whenever we give the patient the complete denture, the patient comes back to us with some sensation, which is like he says or he or she shares that, doctor, I experience a burning sensation in my mouth when I wear this complete denture. So what would have happened is we would have given more pressure on the incisive papilla during your impression making, or during the mental nerve is, since there is total resorption, your denture is in very close proximity with the mental foramen. So how can we get away with this? So whenever you see a class 5 or a class 6 Atwood patient, you have to go in for something called as a double spacer or a double relief in these particular relief areas, so that you do not give unwanted pressure during mastication on incisive papilla and the mental foramen. So when you give excess amount of force to this particular area, then there is an altered taste sensation, sometimes which is called as paresthesia, or you have a burning mouth when the patient is wearing and during the mastication. Yes, another important thing which we fail to tell the patient is that how to maintain a denture. We ask the patient to come after complete denture insertion. We ask the patient to come after 48 hours, which is your first appointment, and then after a week, and then after 6 months. So this is a protocol which you should follow during this procedure. If you find the patient is too old and is not able to take care of himself or herself, then it is mandatory for you to prescribe this particular denture cleanser to all the patients who you deliver the complete dentures. This is nothing but sodium perborate monohydrate tablets, where once every week you have to put in a tablet in a glass of water. It's like a fizz. Okay, I'm sure you must have seen how it bubbles away with all the effervescence. It's a similar thing. So you have to put this and then ask the patient to drop the dentures in this particular glass containing sodium perborate monohydrate for 4 to 5 minutes, and then rinse it off properly. Okay, so the conclusion in today's topic is that there are certain problems which will come after the insertion of a complete denture. Not necessary that an experienced practitioner or a beginner will not face these problems. These problems are faced by everybody. But what sets us apart is that the ability to understand what will be the particular problem or the nature of the problem of the particular patient, and how exactly and how convincingly we treat this patient, and how convincingly we tell the treatment protocol across to the patient. So when I enlisted all these 6 different problems, It is not sure that, yes, definitely if you with knowledge, with skill and with experience, majority of the post-insertion problems can be avoided, but not all. So when the patient comes back to you, if you understand the nature of the problem and give apt solutions to the patient, then that is a good treatment. So the take-home message from my lecture today would be that you should understand all these different problems and know that the patient is going to walk into the clinic with these problems, then I am going to have a certain protocol to treat this particular problem. So if we do that, I think we are going to have a good patient dentist rapport. So my references for today's lecture were Shari, Complete Denture Prosthodontics 3rd edition, Sheldon Winkler, Essentials of Complete Denture Prosthodontics 2nd edition. And thank you all for giving me this opportunity to speak. And if you have any doubts, you can reach me at my mail ID. Thank you.